welcome here to our next session of the Mars webinar series, your partner for market access and pricing strategy. My name is Lutz Former and I will be your moderator tonight. And together with my good friend and boss, Stefan Walzer, the CEO, founder of Mars, is always the last Thursday of the month, but which is not today because due to the holidays, but normally at the last Thursday of the month at 2100 German time and 1200 Pacific time, we have our webinar about the topics on market access and reimbursement. And as already mentioned, today we have something new. We have 2 years DiGA, and of course we're also going fully digital, and now we are going live on LinkedIn, so no more Zoom. So just before we come to our topics today, some few words about Mars. Mars is your partner, your German-speaking market access partner for Austria, Germany, and Switzerland, and we support you all with this pricing and reimbursement strategy, as also with all paperwork for the reimbursement submissions for the German Federal Joint Committee for the DIGAs. As today, we have on the topic for the Swiss Bundesamt für Gesundheit, the BAG, or the Austrian Hauptverband, HVB. And also we support you all with the health economics and of course with the negotiation supports, especially with our cool virtual reality bootcamp. So you want to check that out, please ask us for a free trial. Yes. And also check out, we just published the book on digital health, market access in Germany, digital healthcare in Germany, with Stefan Walzer as the editor. You get it from our good friends at the Springer. And now also, as always with our webinars, questions are welcome. So feel free to ask questions. After the presentation, we will have time for your questions. Well, there's no Zoom question, comments, chat function anymore. So please post your questions here under the video in the comment section, and then we will have and see you that, and then we're going to take that up. And then if you want to rewatch that webinar, that's the previous webinars you can find on our website. So check out our website, www.marketaccess-pricingstrategy.de. And there's a slider that says webinar, and there you can find all. And also, please subscribe to our YouTube channel if so you don't miss any of our webinars. And now we come to our speakers today. Live from Weil am Rhein, we have Dr. Stefan Walzer, the CEO of Mars. Hello, Stefan. Hello, Stefan. Hello to Weil am Rhein.
Hello, everybody. Good evening. Thank you, Yvonne, to be there.
Okay, and we have live from Munich, from Adesso, the leader of the Competence Center Digital Healthcare. Hi, Yvonne. Nice, good to have you on the webinar. Wonderful.
Nice to be here. Thanks for having me.
Yeah, 2 years DIGAs in Germany. Success or loss of opportunity. That's our topic tonight, Stefan. And well, Yvonne and Stefan, did we win it? Did we lose something? Well, you be the judge tonight.
Right? Let's just see how we'll judge. I think, firstly, I think it would be good just to set maybe a bit the scene. I think that's maybe important. So I would probably just start and frame everything, and then obviously would also be happy to hear the thoughts, let's say, from especially at the kind of IT perspective, and obviously also what you from Adesso, and especially one, what you basically as well can report back from the clients. Lutz, you were just writing me the microphone is not that great. Is that correct? I could maybe just still try to change it because we're just at the beginning of the
webinar. Yeah, we're just gonna take that out and cut that out, and we're just gonna stop it now. And Stefan is changing his microphone. Yeah, we're gonna cut that out later. Yeah, that's what we always say. We never do that, but always good to have that. Yeah.
This is what happens when there's a live show, right?
Exactly.
This is part of the experience.
Can you hear me now?
Yes.
Good.
Much better without crackling. Okay.
Perfect. Okay, good.
So just start over with the slide. Yes.
Yes, of course. And I haven't started with right, but I hear myself. Look, maybe. What's happening here? Oh, is that better now? Yes, that's better. It's just for me, right? But you can still hear me, right? Oh, perfect. So now with a bit of a delay and a bit of technical stuff. And Lutz, you might remember, it's probably a bit of tradition, right? Whenever we have DIGAs or digital health in Germany as a topic, there's something happening from a technical perspective. I think last time, I think my internet connection, I think, cracked down. So I think you had to take over for a couple of minutes. So that's a bit of tradition, right? But no
That
worries. Let's just start. I think everybody knows basically that Germany is obviously a large market, a big market, but also with obviously quite a good number of different kind of healthcare payers. So that's also something keeping in mind. But I think that was also, I think, when the lawmakers probably as well put the DiGA law into the kind of, let's call it, game. I think it was really to push the digital healthcare in Germany. I mean, I just had a good, also another podcast episode recording this afternoon, also on DIGAs, and that there the person basically said, look, I mean, 4 years ago we do not, or we haven't really even thought about digital healthcare. It was so far away, and then there was basically kind of, let's call it, agile lawmaking suddenly happening in Germany. So that is something maybe as well keeping in mind. Also, when we maybe discuss later on a bit about success or opportunities and what the current status is, I think that's maybe as well something potentially keeping in mind. Next slide, please, Lutz. So when you think about the reimbursement for healthcare, you still have, let's say, need to have, let's say, two different parts, let's say, a bit in your mind, right? We have here on the left-hand side in green, you have the DIGAs, and we will just cover that in the next couple of minutes for sure. And then you have, let's say, on the right-hand side in blue, we just call it no DIGA, which is basically everything which is clearly not a DIGA. So it's especially risk classes 2B and 3, for example, but also whatever is maybe not going through the DiGA pathway. And we'll not cover that today, but you see there also when you go that pathway, you have the differentiation between, let's say, the inpatient, outpatient, but also in the way how you could potentially get market access reimbursement or funding. But what are DIGAs finally? So how are DIGAs defined? I think that's still the kind of question also after you have seen that slide. Next slide, please, Lutz. Sorry, one back. Yes. So DIGAs are clearly defined. I mean, I said it already on the last slide. It is especially for and only for medical devices risk class 1 and 2A. So that's something very important to start with. Second point is also main function needs to rely mainly on digital technology. So it cannot be a simple kind of, let's say, data collection tool. I think that's something as well keeping in mind. But maybe Yvonne, we will hear as well a bit later also here what is really meant when we speak about the digital technology. I think that's important. The third one, for sure, the purpose is also important. It needs to support the insured person, or it needs to basically support it, or let's say support the kind of care factor of an individual, meaning a patient. So it's very important that it needs to be basically a kind of, let's say, support, a digital support tool in the hands of the patient, which is also a lot of times where, for example, monitoring tools might be maybe not even accepted as DIGAs, even though they might have a digital technology as a main function and might be maybe a risk class of 2A, for example. So that's as well something to keep in mind, especially as this is maybe a core difference to some other countries. And finally, functionalities needs to basically be in one of those directions what you see in the last box in there: detection, treatment, alleviation of disease, injuries, or disabilities. We put monitoring in brackets. Sometimes it could work, but it really depends how that monitoring is then being, let's say, implemented in the care environment. So next slide. So when you have, let's say, defined, yes, my digital health solution is a DIGA, then it's obviously kind of question. This is very simplified, right? I mean, there are, let's say, two different, let's say, pathways. It's one for the preliminary let's say, registration of the DIGA and one for the permanent one. But overall, I think it's keeping in mind that you have those kind of differentiation. First component is you need to be registered in the BfArM registry. This is being done through the so-called BfArM. This is the, let's call it, registration body, and they're looking basically which kind of evidence do you have. They assess it, and if you have, let's say, the requirements met, then you are included there. There are a good number of IT requirements, obviously, but there are also, for example, requirements on the clinical evidence base. Why is that important? I think the core and probably quite unique kind of opportunity in Germany with digital health applications is especially that you have that fast track opportunity, meaning that you do not have, let's say, the final evidence package already available, submitted, but you need to have, call it only, the first, let's say, kind of benefit, let's say, hints in there. So it's maybe enough if you have a small study. It's maybe enough sometimes that you have a study from outside of Germany or other kind of evidences where the BfArM would just say, we see a hint for that benefit. Hence, we basically include you in the preliminary listing, meaning you could still, let's say, charge the price what you have, statutory health insurance funds in Germany to pay the price, and then finally the products basically reimbursed. But at that time or during that time, you need to as well come up with the evidence base, meaning you need to run another DIGA study. After that, happening for 12 months time, there are some excuses. Sometimes you could as well extend it for 2 times 3 months as a maximum. And then you would need to submit the full evidence package, and finally the BfArM can then include you in the permanent listing or not. But that's the registration part, right? So core question also, and we'll see that then as well once we're coming to the pricing bit in a minute. What is happening afterwards? Because once the DIGAs are listed permanently, then 3 months later, the price negotiations with the head of stations of the statutory health insurance funds will start. So what are the requirements? Next slide, please. What are the requirements for the permanent, but also for the preliminary inclusion? Still crackling sound quality. Thank you, Frederick. That's not good. That's strange because I have just changed my microphone over there. And internet looks quite good.
Yeah, that reminds me, in our former mail minister, Dr. Bosbach, right? That's like 20, 30 years ago. He had a interview live on TV with a nice connection. And during that interview, they had suddenly a problem coming up with the line, and he was responsible for that. So that's just in good tradition here with when we have a digital topic and we're talking about fast internet and good quality here in Germany, that some sudden problems occur, which I know I talk all the day to Stefan and never had that. Oh, that's funny. Okay.
It's the classic Vorführ effect, right?
Yeah,
exactly.
Know,
when you do the demonstration, the live show, that's when these things happen. Always, only then.
Only then. Okay, but I can actually jump in there. While we have IT requirements, and this is actually a lot of lists, and maybe Yvonne also can share that because that is actually more your field, the technical field. The IT requirements. It's about 150 detailed questions, and it's not only the question, right, that you're gonna fulfill that and that a requirement. It's like do you meet the ISO standard, or do you meet the standards for barrier-free access, right? So that is a lot of demanding what they do there. You want to share out a little bit spontaneous, Yvonne, on that Annex 1 and 2?
Absolutely. Exactly like you said, there are a lot of individual requirements that need to be met on different topics, right? So it's also about what your deletion concept is, how you're going to store your data, a whole bunch of different requirements, interoperability. Is it machine readable? Is it human readable? Can you actually download it and upload it into another DIGA or into another system. It definitely is worth having a good deep dive into it. Or if you want a shortcut, that part will come later. I'll give you a little tip on how you can shortcut actually spending all that time and digging through these detailed requirements by yourself. So I think, Stefan, we see you again.
Yes.
Can we hear you?
Well?
Yes, we can hear you again without crackling.
Oh.
Yay! Party.
Let's just use the time and don't make jokes. I just try my third microphone for tonight, but you can just jump on the next slide. Thank you, Yvonne, for jumping in. Perfect. So I think cool question still. I mean, before we can really discuss whether it's a success or maybe a lost opportunity, let's call it, I think, what is the current situation? I think as of now, we have 31 DIGAs already included from a quite wide range of different, let's say, disease areas. I mean, you see it here on the slide. I think a good number of it is based from the mental and behavioral disorders. I think not a big surprise. I think just from, let's say, from the way how DIGAs are as well being programmed and the idea behind it, and also with the, let's say, risk classes 1 and 2A, I think makes a lot of sense from there. And then I think you have a good split between the different other disease areas with a slight kind of, let's say, further higher number of DIGAs from the nervous system and also from the disease of the musculoskeletal system and the connective tissues. I think the rest are quite evenly, let's call it, distributed. Next slide, please. I think cool question also, let's say, to maybe discuss as well a bit later on, is how many applications have been, let's say, tried? How many applications have been assessed by the BfArM? I think what you see, we have now 2 years, the DIGA pathway. In the 2 years, we had 130 applications. It's actual numbers out of the BfArM. So the BfArM have published these. Out of those, we had 97 applications for the preliminary inclusion and 33 for the permanent inclusion. And then you see suddenly a good number being again withdrawn, 72. Why withdrawn? I think that's basically after the discussions with the BfArM. So when they, let's say, discuss with you potential holes, potential issues, where they would just say, look, you have now finally the kind of, let's call it a decision in a way as a company, right? If you still want to push it further, then the BfArM might potentially reject you, or you withdraw it and could potentially still work on the case, which is sometimes obviously as well important. Still, there were 11 rejected, 14 are still in process as of May, and 31 were positively decided. Out of those positively decided ones, we had 12 permanently included and 19 preliminary included. So it's quite, let's say, 1/3 of it was permanently and 2/3 of it was currently preliminary accepted, meaning that those 19 are currently running their German DIGA studies or have done that and are now applying again for the permanent inclusion. Next slide, please. So how about the price? You see on the right-hand side the current prices. So we have, as of May, we have 4 products, 4 DIGAs, which went through the first round of the price negotiations. So you see that already as well in that, let's say, bar chart. I think we have a range of prices. Let's call it between 200 and 700 euros. I think the one on the very left-hand side, Movendo, I think there's a bit of a history behind that. They have as well a couple of selective contracts, etc. I would not, to be honest, just between us, right? We're just alone. Those 119 euros are, let's say, a bit strange to me to see. But this is just my personal opinion. I know that pricing is a hot topic within the DIGAs, and there are a lot of, let's say, discussions whether prices are maybe too high or maybe even too low. I think there are different, let's say, worlds in there. In general, there are 4 possible reimbursement periods to choose from: 30, 60, 90 days, or lifetime. All DIGAs except Movendo and my tinnitus app opted for a 90-day reimbursement period, just keeping that in mind. And the mean price was roughly 440 euros. Median was not that far away. It was 490 euros. Important, is we had the arbitration board decision on Somnio, where I think one could also understand quite well how, let's say, also and especially the arbitration board is coming up with the pricing on DIGAs. I think we have had also a couple of other webinars on there. Important, keep in mind what you do with the selective contract on the pricing there. Keep in mind what you do with your prices abroad, so outside of Germany, also direct sales to patients. And for sure, then keep in mind what your, let's say, added benefit of the product finally is. As said a couple of minutes beforehand, but I still had those crackles in my microphone, is the first part is the BfArM, but BfArM is only registration. Second part is then the question whether there's an added benefit, meaning the payer side in Germany is also checking that again. So what you see, quite huge given after the price negotiations. Somnio minus 52%, Velibra as well, Elevida minus 67%, and Deprexis with minus 29%. Next one, please, Lutz. So, as said already before, maybe there is a bit of a misunderstanding of the BfArM task. I think the responsibility of the BfArM is, or let's say the question around it maybe, is especially can a DIGA demonstrate a patient and or process benefit? This is part of the whole kind of benefit assessment there, but it's only benefit, it's not an additional benefit, meaning it's very similar what you maybe know from the drug area when you discuss with the EMA, with the FDA, where sometimes even placebo-controlled trials are accepted, but then you're approaching payers from a pricing perspective and suddenly you get negative feedback there. So it's then the next part, the responsibility of the German payers, and they are basically asking how high is the additional benefit of the DIGA compared to the current care situation, and how can this be quantified. And this is really important because this is then driving a price, and this is also what you have seen after the arbitration board decision on Somnio, for example. Next slide, please. Finally, and I will not go through that in detail, I think you can, if you rewatch it and just press the pause button, you can maybe read everything there. A couple of more slides would you have if you contact us. But there is even now the kind of agreement that there might be and will be maximum reimbursement amounts for the DIGAs given different disease areas. So that's a very important component also when you plan your prices and when you plan your pricing. I think it's also then the question, what is your added benefit? First of all, which disease area, how many DIGAs were there included? And then there might be already a maximum reimbursement value available. And this is obviously a very important consideration when you potentially also plan then the launch into Germany. Next slide, please. So, success or lost opportunity, the last bit of it, obviously, if we discuss about, let's say, sales, you have the two components. We have discussed about the price, and then we have to discuss about as well the number of prescriptions or utilizations. I think what you see here, this is just out of the latest report of the German payer side. They have analyzed the first year of DIGA, so you see that September 20 to September 21. Obviously, some of those were not directly launched around the September timeline, so be cautious when you have a look on that. But it's just important. I mean, the mostly, let's say, sold or used DIGAs were Calmeda and Vivira with a bit more than 8,000 prescriptions overall in that 12-month period. And then you have a couple of others like Scenario, MSense, and Somnio, somewhere around the 5,000 prescriptions overall. So let's say there's still some room for improvement, I would say. I'm really believe in DIGAs, right? Don't get me wrong, but I think currently I would not say probably lost opportunity, but I would also not yet say it's a big success. I think the ground is maybe there, but I think we all probably need to make it successful also for the future of the healthcare system. That's my kind of current view, but obviously looking forward to get then also the view from your side, Yvonne.
And now we have Yvonne Grundler here on the webinar, the Competence Center Leader for the DIGAs.
Perfect. If you go to the next slide, please. So, Stefan, you already said, is it a success? Is it a lost opportunity? Well, let's go through it a little bit more deeply one by one. Obviously, as you already mentioned, we've faced a number of hurdles and challenges and also setbacks, right? You mentioned, for example, the pricing that for a few of the DIGAs has actually been quite significantly dropped. You also mentioned a few factors that played into that. So, you know, we often talk about first mover advantage. Maybe in this situation, it's actually an advantage not to be one of the very, very first movers so that we can actually learn from what has gone before. But yeah, that definitely has been an unfortunate setback for a few of our fellow DIGA manufacturers, let's call it that, in the system, that the pricing has actually been decreased, the final pricing. Another setback or challenge is people withdrawing their DIGAs, right? You mentioned as well before, there's this opportunity to be provisionally included in the DIGA catalog or the DIGA directory while you're actually conducting your study to prove your positive care effect. And from what we see, the main reason for withdrawal is actually this proof of effectiveness study. What we've also seen in the market and what we've heard from applicants in the process is that the BfArM has actually slightly tightened their requirements so that now your sample size actually needs to be higher. While they're not requiring an actual level of significance, you know, P is smaller than 5%, as you would for, you know, your kind of gold standard RCTs, they are actually looking for something that is moving towards that, looking for about 10%, whereas previously, you know, that was not actually, there was no level set at all. So yeah, we see as the market matures and the studies are coming back that the BfArM is actually kind of tightening it up a bit and causing obviously some of the players to withdraw for this point in time. And what's interesting as well, speaking to the players, is not that they're saying they're giving up, which I think is very encouraging. You know, temporary pause, readjustment, getting more data does not mean they're not going to resubmit. And I think that's also important to note here. We're still in a very early stage of this market developing. So we can still see how this all plays out with those that have been preliminarily accepted and those that will resubmit with a stronger and larger data set. And then a final hurdle that we saw at the beginning or feared at the beginning was this change from MDD to MDR. That change was making Class 1 self-certification more challenging. And with Class 2A, as many of you know, you basically need a notified body to actually certify you. And as we all know, the spaces at the notified bodies are limited. And that's actually one of the hurdles, is getting that slot and timing it so that you'll be ready for the audits and the conversations, and you know, getting that slot in the future and then planning your development on that way and hitting that time mark. So that was perceived as a challenge and definitely made it a bit more difficult for a period of time as well. If you could move to the next slide, please. But the good news is some things also got easier, right? So I mentioned earlier, I'd give you a little shortcut in terms of those requirements in the DIGA, the annexes that you need to meet. So we actually see players like ourselves at Adesso who have developed regulatory conform technology, which provides you with a whole component system that you can just use to manufacture your DIGA. So you don't have to read through all those 150 lines. We've done that work for you. And actually, you can just take those components off the shelf, the ones that you want and the ones that you need to manufacture your DIGA. No, we cannot take all of the work from you. You still have to conduct a clinical study. You still have to think about, you know, your concept, your pricing strategy, etc. But at least there's a bit of respite there in terms of meeting all the different regulatory requirements on the DGAF level, on the medical product level, all the ISOs, GDPR, etc., BSI, all those standards are already met. Furthermore, you'll find a lot of help actually at each step of navigating this process. So within Adesso, but also our partners Hele and of course also Mars, we can help you along this whole journey, right? We can help you not only with these technical components, but also with advice, consultant services on how to create your study, how to make sure you can get through it, what to say to the BfArM, because it's actually quite a process and a conversation, and how you manage that conversation with the BfArM also massively impacts how you get through the process. And then, of course, with Lutz and Stefan, you can get assistance on pricing strategies as well. And what I can say there is definitely don't think that you can leave it till the very end, because then you'll make the easy to make mistakes along the way. And that obviously, then you've already set the tracks for those pricing negotiations. So do think about those upfront. And then I just mentioned this change from MDD to MDR and fear that it's very difficult to get into class 1. And for a very long period, I think the first one only came out like beginning of this year, I think it was, there was no class 1 DIGA in the catalog or the directory. But now actually there are a few. And so now that there's this precedent set, we can also look at how to argue the case in front of the local authorities to get that self-certification, which obviously cuts down the time to market, does not require the time slot with the notified bodies and the class 2A certification. Now, this obviously doesn't apply to every single potential DIGA. Some of them will quite clearly still be class 2A, but at least we know that for some, class 1 is possible, is accepted, and that will reduce the hurdle and the barriers of entry for some of the DIGAs wanting to enter into the directory. If you go to the next slide, please. So what do we learn out of all of this, right? All the mistakes that we've made along the way, all the successes that we've also seen, right? We do have a number of DIGAs that have actually made it in and actually are being prescribed, which, I don't have numbers on the selective contracts, but I would guess that it's actually quite higher than the selective contract health apps that were used and promoted in the years before. So yeah, understand the process well, right? As you saw, there's quite a journey to go on. Don't be daunted by it, right? It is a journey, but there is assistance at every step of the way. And actually now that we're moving towards 2 years of this process, we can actually see what DIGAs that have moved from start to finish. And so if you look at that entire journey, then you can actually plan ahead and think of the pitfalls ahead of time. And don't forget, right, you still need to market the app. Just because you've made it into the directory does not mean that it just flies off the shelves and after we'll just prescribe it and every patient will be aware of it. That is something that I think we're still seeing some of the original first waves of DIGAs struggling with, because they were so busy trying to get through that process and they were the first wave. They didn't have those precedents set, that is still something they're working on. And then, of course, you can see some are doing it very successfully. The prescription numbers will also increase. Second point is, get support where there's needed. Every organization has core competencies, and not everyone or no one can do everything perfectly, right? So understand what the things are that you can do really well, and where you can find partners or consultants to help you match those areas where you just need a little bit of assistance. And as mentioned, there are actually quite a number of players on the market now for everything ranging from BfArM management, pricing, technology, clinical trials, etc. So you can really build your team there if you cannot build it all within your core team and within your own organization. Then, I know it seems like many years away, right? Pricing, that's like 2 years down the road. You first have to get into the directory, etc., etc. But that is something that you want to think about right at the beginning. It ties in with the first part, understanding the process well. There are mistakes that you can make along the way, little ones that are very easily avoidable. So just thinking about that entire process and making sure you avoid those small easily avoidable mistakes that cost a lot in back end. That's quite a crucial one to think of. And, it's a long process, but don't be afraid of the process. We're in Germany. We like our processes. The good news is, if you tick all the boxes, you will make it into the catalog, right? Like, in a way, as unappealing as it sounds, and as bureaucratic as it sounds, the beauty of bureaucracy and administration is, if you go down the process and just go tick, 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 you'll come out at the end. So as you see, it is possible, and it will still be possible. Just make sure that you know what those boxes are that you need to tick. And the next point is a very interesting one that I've been, a lot of conversations I've been having in the last few months is, should I even be a DIGA, right? Why don't I just go and talk to the health insurances directly? And when I hear this, I find it a very interesting comment, because for years and years and years, health app manufacturers and distributors and creators have been knocking on the doors of the German health insurances, and no one's been opening those doors, right? Like, it's been really painful processes for health apps to get these selective contracts. Very few have gotten these selective contracts. Pricing, has been variable. And even when there was a price agreed, there still were no touch points to actually market the apps to the insured members. So there were still no patients using the apps. And I find it quite astonishing that the hurdles of becoming a DIGA are making people wanting to just jump back to that previous model, where we've actually seen for years that didn't really work. And that's kind of also why this whole process was set up, that there's actually a very clear route to reimbursement. So don't assume that, going back to selective contracts is going to be easier, right? Like, a lot of people are still trying now, and we're not really seeing to take up very quickly, and we're certainly not seeing the patients getting those apps into their hands very quickly. I'm not saying that it's not impossible, and I'm not saying that it's not potentially moving more quickly now that there's more pressure on the public health insurances to adopt health technology and digital technology, but kind of just saying, okay, this is too hard, let me just go back to that, without weighing the pros and cons. I would at least think about the different models and say, okay, what's going to work for me there? Do I all the connections to the health insurances? Are those doors going to open easily? Because here with the DIGA, you do actually have a very clear route to reimbursement, and that opens up a market of 70 million insured people in Germany. That's a huge market, depending on the condition of caller. But I think do not underestimate what you can achieve if you make the effort of going down this route. And then that also ties to the last point. At the end of the day, it's also just one model, right? And depending on what your product is and achieving care, there may also be other models, right? Right now, we've seen a lot of individual, in the first wave, very individual digital health apps, mobile apps. But we're starting to see players move into the market which are combining hardware with the software and looking at that being a complete DIGA that has not, the hardware has, ones that are listed been not mandatory, so not part of the core DIGA. That is also one model, right? If you have hardware and you want to enter this German market, to package it and have the whole thing as DIGA, if the positive care effect and this package fulfills the DIGA requirements, right? So there are different ways to go about it depending on what your product is and how it's actually used by the patient and within the system. Definitely worth a look at, in my opinion. If you go to the next slide. And finally, the big question, success or lost opportunity. So if you ask me, I think, things that speak for lost opportunity is this poor market education, right? 2 years down the line, I speak to a lot of players and they're like, oh, DIGA, what's that? It's like, it's one of the biggest changes in our legislative framework. It's like a huge deal. It's a new thing in the world, first market to actually have this. And even players in the German market still don't know. So I think we lost the opportunity there, but first mover, so we learn from our mistakes, right? And this lack of market education, I think, also unfortunately resulted in not as much buy-in being created as there could have been with doctors, nor with the GKV, also with the public insurances. That's, I think, a real lost opportunity. That's a shame, because actually we could use this process to really benefit a lot of patients in the system. Then, of course, for the individual players, a lot of potential DIGAs were withdrawn and lost along the way. So that's a shame, because I'm sure there were some good solutions there. Hopefully they'll find other models, or, resubmit evidence once they become stronger, tightened up their product a bit. It's not over yet, right? So maybe we'll see them again. And I think the last one is a potential, like very large potential lost opportunity, in that if we're afraid of this process, or if there's too much resistance, it actually has a danger of becoming like a negative self-fulfilling prophecy, right? And because people believe that it's going to fail and no one tries, then there are no DIGAs in the market and the whole thing just collapses. And that would be, I think, the biggest shame, if we don't actually have a market because we just think, oh, there will be no market, and don't move in any way. Then there are also arguments that speak for success, right? We're the first country to implement such a reimbursement route. It still hasn't been done anywhere else yet. France actually is following pretty quickly. They're improving the process. So what I said about poor market education, they've dedicated funds. I think it was 80 million euros for market education, which is a huge amount of money. I think that's really good that they're learning from the things that should have been improved in Germany and improving it with their launch. And they're also providing a lot of money to support clinical trials, which is another potential barrier for the market in Germany. So I think that in itself, that we've been brave enough to put something out there that can be improved upon and is now being improved upon, is a huge success for healthcare in general. And then, of course, we cannot forget, there are over 30 DIGAs now in the catalog, right? And those are improving patient care. And these are proven to improve patient care. And that, I think, is a huge success. We should not underestimate, if we can keep growing this market and keep going down this path, how much impact we can actually have on patients. So overall, only time will tell, right? Like, you can argue either side, but it's also up to us, right? That we actually do our part to make this a success, and bring it through the goalpost, as we say in German. So, yeah. And that was me.
Thank you, Yvonne. And we have also Stefan back.
Sure.
Slightly crackling, but good to have you here, Stefan and Yvonne, for our questions of our lovely audience, actually. And we have really some interesting and good questions here. So the first questions here of Andreas, he's asking us, is it price per year or per access? So please, can you explain us again how that DIGA is reimbursed, the options here?
Yeah, I think that was based, or let's say, going back to the graph what we have shown, the bar chart there. So this is basically the reimbursement for the reimbursement period you have chosen. So it's the price per 90 days. So it's basically a quarter. Yep.
Yeah, and there are like for some apps, there are like for some DIGAs, there are rescriptions, so you can actually have then up to 90 days, so a quarter, and 4 quarters is a year, and then you have your annual treatment costs. But keeping in mind, if the patient stops the therapy, right, he will not go to the physician and ask for a new prescription. So the treatment stops after 90 days or 180 days or 270 days. That's the one option with a period option of 30, 60, and 90 days. Or there's the once a lifetime options. So you only get, as a DIGA manufacturer, once at the beginning the money, and that's it. And the app is working until the software runs out.
Exactly.
Yeah. Okay. Then is another really nice questions about the rumors questions, right? Is it true that many companies prefer to withdraw rather than being rejected? right? And that's also, we have it on one slide. Let me check here. That high numbers of here with 72 withdrawn applications from the BfArM. Wow, that's a big number.
Yes, I mean, at the end of the day, I think it's I would actually say yes. I think most of them, I think, prefer to do it on their own. So simply withdraw instead of being rejected. I think it, obviously, if you keep in mind also, let's say, public opinions, and potentially even, let's say, communication to the outside world / investors, funders, etc. I think that it's always obviously better if you're still in the driving seat, and that's what you basically can show if you say, look, we have had discussion with the regulators, we have taken that into account, but we have now withdrawn it and work on it instead of just say, look, we have submitted, we were rejected. That's obviously a much worse outcome, I would say. I don't know, Yvonne, what you have maybe heard from your clients.
Yeah, absolutely. 100% agree. And I think, as I mentioned, this whole thing is a process, right? You are in interaction with the BfArM. And if there are notable reasons why they would reject, they are very fair, right? They will say, this does not look good. So why would you keep running against a wall when you know you're going to crash right into it? Then it's better to say, okay, maybe we should pause and, find a different route, like, maybe break down the wall a little bit, and then go again when we are more confident that we'll actually get through.
Yeah. That's just the way it is. So yes, it is true. Most of them are just withdrawn by themselves. It's not a rumor. Okay, next question. There are many criteria that are taken into account during evaluations, so interoperability, the need, the unmet need, right? Stuff like that, the data security. However, to what extent is the capacity of generating data, for example, for the health system or the interest of innovation, right, a decisive criteria for inclusion? Now, that's a good question.
I love the question. I love the question because I think it shows the way, you're thinking ahead and how you can benefit the system. I have to maybe put a dampener on it, and I'm very sorry to do that. Unfortunately, it counts exactly for 0. At the end of the day, what the DiGA is supposed to be is a digital medicine. And when you have some kind of medicine or some kind of digital therapy, you have to say what the intended use is, right? And what the actual outcome should be from taking this medicine, this digital medicine. And your endpoints of your study need to be related to that, right? So this additional value of generating data that you understand what's going on, etc., if that just does not figure into it, unfortunately. I wish it would, but you can think about it as, what would you need to do if you wanted to get a medication, a pharmaceutical product, a drug into the market, right? It's from a process point of view, it's like that.
Yeah, I mean, I would also maybe just simply add, I think, if I got the question right, I mean, the capacity of generating data, meaning that you are running a study to show basically the benefit either to the healthcare system, to the patient, and or generally to the process, right, which is also a component of the DiGA, is part and core component basically of the whole kind of DiGA system itself, right? So that's basically, I think, the core idea of the whole kind of fast track of the DiGA system. So you do not need to have a final, let's say, proof of your benefit. What you normally need to have when you, let's say, approach especially payers as well. I think that's also I would say, the big fight between still the registration and the pricing part of it, right? But that was maybe a bit also eased, that pricing is now only being done after the final inclusion into the DiGA registry. But I think this is a core component, right? You need to have a kind of hint, as I said it beforehand, a hint towards a benefit. Sometimes one-arm study might potentially be enough. There's a huge range of evidences which might be maybe accepted by the BfArM, but then you need to have obviously a clear plan how your DiGA study should look like, right? Which centers, which study endpoints, which study type, etc., etc. And if that is then acceptable and accepted by the BfArM, then you're included in the preliminary listing. So I would also say this is part of it.
That's true. Sorry, maybe I misunderstood the question. So if
maybe it was
Rainer,
me.
if you want to, if you want to clarify, or if we didn't answer your question, ask again. We're so sometimes.
Yes, I actually got the question that way, that is the BfArM actually honoring innovation? And the answer is no.
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 If that's the question, then no.
No.
If it's about, you
Yeah.
know, do you have to generate the data to prove your positive care effect? Yes.
Exactly.
So innovation 3 times, no, no, no. Okay, let's move on to the next question. Is the evidence that the DIGAs provide to get approved publicly available?
Yes.
So yes,
Some of
yeah,
it, please, Yvonne.
yeah, exactly. In the DIGA directory, there's actually quite a lot that you can find out on the positive care effect, how the study was set up, etc. You need to go into the actual DIGA and then scroll down, and there's like a lot of information there. Is the data, like actual raw data, available? No.
I know, but a lot of times you have the references, right? So if you
That's
basically go into the DIGA registry and just let's say check for the references, especially for the studies which have been used in the submission, then you normally find those, and then you get the original data.
Great. Yes, and also there's a rule of the BfArM or in the law that says that the clinical data has to be published, right? It's not saying that you have to publish the CSR, the clinical study report, but somehow the data has to be published in a publication. So you will find also some data there, probably in journals somewhere published. Yes, then I go just to the next question, which is, are there example of blockbusters in this area? So what are blockbusters? Of DIGA
I think
blockbusters here?
if you take the blockbuster from the pharmaceutical industry, I would simply say no, because there are no blockbusters yet available, at least, right? And I think that's maybe also a bit of the fear. I don't know whether it's a fear, but I would feel it as fear by the health insurance companies, right? But I mean, as you see, I mean, we have seen a couple of DIGAs with, let's say, quite reasonable number of prescriptions in utilization. But I think, as I think, Yvonne, you have as well, you said, I think it's very important to also plan accordingly, and before you launch, how you communicate and how you also, let's say, get buy-in by physicians, maybe also by patient groups, and for sure also get the insights from the payers, that you do not get stuck, let's say, at the end of the day, for example, either in the price negotiation, but also keep in mind what some health insurance companies have done in the past with selective contracts. They have pushed for those digital health applications, or let's say solutions, probably better said, within their insured patients. So that's still a kind of way where what I think is still missing. Obviously, with the caveat, a lot of those DIGA companies are quite small companies, so it's not the big pharma companies basically who are then running that. So that's maybe my kind of point on that.
Great. And then we are now coming to the really hot topic about the hardware. Is hardware also reimbursed along with the software as long as the combination fulfills positive care requirements?
So
Yes.
It can, right? And I think that's exactly how you define it. You know, you mentioned the word combination, fulfilling the positive care requirements, right? And that's exactly the point. The hardware itself, you know, if you can just use the hardware and it works, it's not a DIGA, right? It's like a medical device on its own. You have to have the combination. The combination needs to be the one that fulfills the positive care requirement. And it cannot be an object of daily use, right? So like a blood glucose monitor, if you just add an app to it, that is not acceptable, as an example, right? But yes, those are the interesting discussions that we're having right now. And I think this is the part that I'm really excited about. Now that the first wave of solo DIGAs, let's call it that, where it's software only, are out, hardware often takes longer, right? If you also are developing the product from scratch, it takes longer. And now what can you do if you combine this hardware with the software? That's the interesting part. So yeah, I think we should watch this space. And if anyone is thinking of developing hardware or is developing hardware and hasn't entered the market yet, I think this definitely is an interesting route into the market.
Yeah, I mean, there is an example, but I would need to omit. I'm not exactly sure how, or at least I'm no more sure how the pricing really works there. But there is one of the DIGAs in the psychiatric field also has, besides, let's say, the software, they are also combined with virtual reality glasses, right? And both only in the combination are basically then, let's say, being used there. I think it's against some kind of fears and it's, all of that kind of stuff. So you cannot just use one or the other to get the patient benefit, only if you combine it. So that's maybe the kind of, but again, I'm not sure how they have again done the pricing. I think it's probably just an overall pricing, and the hardware is just a part of it.
Yeah,
Exactly.
the hardware is actually shipped for free, so the hardware is
that's what I
included
thought
in the
exactly.
price.
Yeah, I was not more
Yeah.
exactly sure, but yeah, good point.
Yeah.
Yeah.
Great point. Where they actually you put the virtual glasses on, and then it just shows you, like, for example, when you're afraid to speak to people with a big audience, right? Then they show you the big audience, and you can just train that situation.
Yeah.
Yeah. So, what would be your top 3 tips or main points for another country looking to implement a DIGA-like regulation? Well, that's a good question. That's a good question. Well, it's depending on your healthcare system actually up there, and how you're probably, if you're like in the Baltics, like in Letland or something, they do not have any problems with the DIGAs, so they're a little bit more.
Yeah, I mean, what I personally still believe is that whole kind of fast track idea is I think, especially in that area, is really good, because I mean, at the end of the day, we're not acting in a field like with drugs, where you can basically harm patients, right? With safety, adverse events, those kind of issues, right? And this is not what we have with DIGAs. So you can actually really go into the kind of area and just say, look, we have proven that the digital health solution can or could do what it should be doing, and hence we have tried it in, for example, in a small study, and then while you basically develop the, let's say, the full evidence package, you can still get reimbursement. I think this is I personally think, a smart idea, especially if you want to get a push into the digital health area in your country. I think this is, to me, I think one of the main points I would really take. I mean, others, I mean, it's difficult to say, right? I mean, I would probably think of being a bit more open for, let's say, I think we had it before, innovation, health innovation, being priced for it. I think, but there are probably different components of it. But I think, to me, the fast track option is the key point what I would really implement.
I think if we look at what France is planning to do, right, setting aside dedicated support for market education for the clinical trials is very smart, because you don't want to have these very tough requirements for companies to need to meet and then not support that, because that basically means that small companies, new companies, startups would be, in essence, priced out of trying this route, right? So I think that is a smart thing to do. And they're also, I heard, going down the route of not having pure digital medicines, in that the positive care effect only comes from a purely digital solution, right? So in Germany, if you have like HCP interaction that can influence that, and you cannot in your study very clearly prove that HCP interaction did not have any effect, then you don't count as a DIGA. And actually, for like service design and patient pathways, I think that's unfortunately a bit restrictive, right? There are a lot of indications, a lot of care situations where having HCP input actually is helpful. What are we trying to achieve in the end? It's to improve patient care, right? So I can see why in Germany we didn't do it that way. We didn't include like telemedicine options and human support into it. We excluded it. But I do think in the bigger picture that actually might have been a loss. So thinking about how you might be able to include that. If it turns into a pricing issue where you're saying, oh, well, you know, if there's a human interaction, well, that's already paid for. And then there's also this digital part paid for. Okay, then we can think about like pricing models, maybe more like what was called DIPA, which was for care solutions, where there was a fixed price because there was a human interaction, right? And that's actually the route that France also originally was thinking of going down, is that they set the pricing. So you don't even have this whole pricing negotiation. You don't have this fear of the health insurance is saying, oh, the pricing will be set so ridiculously high that we don't even want DIGAs coming into the market. Now, depending on your healthcare system, that might not be possible, right? Like it depends on if you have like a single payer system or if you have a kind of national universal basic care. So it kind of really depends on what your country's like system is set up to be. And to be honest, also your level of digitization, right? Germany, I feel in many respects is still a bit behind. We still have some catching up to do in terms of general digitalization. I would also look how these DIGAs or DIGA-like products can really integrate into entire care pathways, into other information systems, other digital systems, other digital care models or hybrid care models, and maybe not, keep it as tight as pure digital medicines, if that makes sense.
Yeah, I agree.
Yeah, great. Thank you for that insight. And now I want to say hello to Jamie from Canada, actually, who's our lovely audience member, is always here on the show with us. And he had today an interesting question because Health Canada spoke at MedTech today concerning digital health products. Healthcare finds regulating adaptive models troublesome. Healthcare only approves logged algorithms for now. And how about German? The BfArM is dealing with that problem. Yvonne or Stefan?
Yeah, it's similar. They also find it very troublesome. It is hard, right? And so it's very restricted. It is something that I think we will learn as we go. Right now, also because of the risk classes and what,
That's what I
you
thought,
could do if you let it run rampant, let's say. The usage is very, very restricted anyway, right? So I think as the market develops, as our products develop, we will see changes. But yeah, right now it's basically the same. It's locked, very limited, and
yeah. And
yeah,
there's
I think the biggest issue I see is basically, as you said as well, I think it will be most likely risk class at least 2B, probably even more. But I mean, then let's say the DIGA pathway is already gone, and finally you're basically ending up in the method evaluation with the GBA. But even there, I mean, I would doubt, to be honest, that they could really deal currently already with machine learning, right? It is simply something else than a, call it stupid, medical device, right? You just build it and it always does the same thing. I mean, with a learning system, it is something different. But I think what we also know, I mean, payers are aware of it, so they're discussing it. They are trying to adapt as well. But I think currently, I would say the systems, the market access, the reimbursement systems are not yet there. So I would agree with you, Yvonne. I think it's as difficult probably as everywhere else, probably. Maybe outside of the US, I don't know. I'm not a US expert.
I think what will be interesting as well is as we see more like clinical decision support systems coming out that are based on KI and how humans then interact with it, and then the care that comes out of that, right? People will get more comfortable with having some kind of AI, some kind of adaptive model, et cetera, around. And then I think we'll get more and more open, right? We're still, I feel like, 25 years ago, my dad said, oh, artificial intelligence is the next big thing. Virtual reality is the next big thing. And we're still working on it, right? It's not quite there yet.
Good point.
Great. Yeah. And that's also something when you have like a change of your product and the BfArM is proven if it's a significant change, right? And if it's a significant change, you have to reapply for the BfArM directory. So that's also, so if you're even have an improvement of your product, which is in the digital sector probably better than with a drug, right? Or a medical device, then or easier to do, then probably you're just gonna kicked out of the BfArM registry and have to apply new. And I mean, if it's a new algorithm or a changed algorithm, you have to prove, you have to bring new evidence. That's a bad thing. Yes, and now we are coming almost to the end. Jasper is asking us if you have, do you know of which of the current listed DIGAs has the strongest clinical evidence and the best health economics?
I would generally say the strongest clinical evidence is probably with the ones which were permanently included in the DIGA registries. I think they normally have an RCT available against at least a comparator which was accepted by the BfArM. When that is, let's say, the kind of current, let's say, assumed standard of care by the payers is maybe another question. But I mean, if you have a look on some of the Hello Better, or I personally think the SOMIA study is a very good one, even though that I think some are debating about it. But I think if you just take those into account, I think I've shown before, and I think we have 12 DIGAs now included permanently. I think they have a very good clinical evidence. The best health economics is probably more coming out of other jurisdictions, right? I mean, in Germany, we still don't need cost effectiveness or anything like that. I mean, even though that some DIGA companies are developing it and some are even publishing it, but I think in Germany, it's at least not a core component of the whole kind of process. I mean, we know that also in the arbitration board with the drugs, I think if there's no other real anchor available, and if there are maybe long-term effects which might also help, then it was taken still rarely into account also in the drug area. And especially at the time when Professor Walzer, who is now the head of the arbitration board, has been heading the drug arbitration board, but still, it's not a core component. And at the end of the day, you also don't see it. So I think we can probably only answer the first part of it, which is the clinical evidence.
Yes, I mean, we did once checked all the clinical trials, and there were like a huge discrepancy between 30 patients. That's like somehow the lowest number for the preliminary, and then it went actually up to 1,200 patients in clinical trials, right? It's also depending on the field of application, on your indication you're using, but you want to check out first permanent listings there. Also commenting here that Depraxis had like 11 or 13 studies. So some of the DIGA, they have a lot of good evidence brought in there. Yes, now also Matthew is commenting to Jamie and refers to the PubMed, so you can see that here, his article in the comments. And the last question for tonight, we go again to Canada. And Jamie is asking, is there a reimbursement issue when a pharmaceutical product is bundled with a digital health product? So that could be, for example, you have an app and a drug. Is that what you mean? The two products have complementary effects on efficacy. How do reimbursement decision makers deal with that bundling? Oh, that's a tricky question.
So that's interesting. So pharma product plus software.
Yeah.
I mean, we have already the issues if you just take, let's say, companion diagnostic and the drug, right? I mean, I think this is already a big debate, right? I mean, how should it be assessed, and which, let's say, which part of the market access pathway you would need to go, or if it's maybe separately being or need to be assessed, which is, I think, normally not really doable. I think currently I would say it's not applicable for DIGAs. I would say I think a DIGA is individual. I think, and otherwise we might anyway end up in either the method assessment or maybe the assessment in the drug area when it's more really a kind of add-on to the drug. But I personally would say if you have such a case, go and consult the GBA. And they might still have also or getting headaches with that question as well. I think that's at least no clear pathway yet.
So it was just off the field of diabetes, where it actually makes sense, right, to get to track the effects of your drug, right, and then adjust the algorithm, for example.
I think that's probably not yet really the effect, right? I mean, if you just track, for example, the insulin you're taking, right, that's another part, right? And then you need to be careful if it's really a kind of digital health component or whether it's rather a kind of aid, right, and Hilfsmittel in the German
medical
context.
device.
I mean, that's another kind of path in a way. So it's very tricky, and it really depends what it really does.
But and I think that's exactly the point, right? The DIGA at the end of the day is a digital health application, right? So if you had, let's say, a piece of hardware that somehow did the titration or the dosing or something like that compared with software, like then it's like a Hilfsmittel. The hardware part is digital in some way, right? It's not the actual thing that's actually in the syringe, let's call it, that is being titrated that makes a difference. And any insulin being put into it would make the same difference. Then, then it's digital again, right? So it's really, where do you draw that line? But if the active ingredient of the pharmaceutical product, of the drug itself, is the one that's creating the impact, that part is not digital, right? So if I think like the BfArM and think, again, very German, what are the check boxes I need to tick? Doesn't tick the box of the digital part.
Yeah, that's also a tricky one. And with the field of diabetes, I mean, if I would also say that it's not DIGA applicable because it will be listed as at least class 2B device.
That as well, exactly.
And then the DIGA pathway is gone.
Mm-hmm.
Because DIGAs only are until class 2A.
Yeah,
that was it for actually tonight. Before we come to the end here, the first and only Market Access podcast by Mars. So, Stefan, you have made 2 wonderful episodes, one with our good friend Daniel Maticiewicz and Ms. Geyer from the DIGA association here, 1 year DIGA. Now we have 2 years DIGA with Yvonne. That was the 1 year DIGA episode. And the other one with a great teacher, great Professor Walzer here, who was the chair of the arbitration board for the drugs and who's now the chair for the arbitration board for the DIGAs. And the 8th episode of Stefan's podcast is about what happens when negotiations fall. Now that's actually, you want to listen, just great education here you can do. And then let me point out our next webinar here with our good friend René Godau from Ashfield. How can SMEs be successful in Europe within and beyond market access? And we set up that event tomorrow, and then you can register here at LinkedIn. And that's the last Thursday in June at 9 p.m. CNT and noon Pacific time. So register here on LinkedIn. We hope you enjoyed it, and that was it for actually today. Thank you very much for watching us here on LinkedIn. You can also thank you all for the comments here that work well, and if you want to rewatch it, you can rewatch it on YouTube. So stay safe and have a good day, have a good night. See you.
Thank you all. Thank you, Yvonne. Thank you.
Thank you.
Good evening.
Bye.
Bye.